right, guys. Welcome to our echo lectures. You guys know I'm obsessed. And just a little like thing before we start the lecture. We're all really bad at echo. Just know that. And this is a way for us to try to get a little better at the echoes. Right?
We're better than the cardiology.
All right. So this is probably my most important slide. Because we're so bad at echo, it's just know that every image that you clip is a 2D image of a 3D structure. You're getting one little slice of something that has an infinite number of slices, right? So if you find something, please make sure you back it up in another view. So let's start with plaques. Just a little bit of tips. So COPD, we have a lot of these patients, right? COPD, asthmatics, you know, the guys are like 6'4" and like smoke like chimneys. Their thoraxes are like ridiculously long. If you go to your normal third, fourth intercostal space, you're just going to see one. And you're going to be frustrated. And I see people like going all over the place looking for the heart. And eventually you find it all the way down here. So why don't you start down there, right? For hyperinflated patients, just try to start a little bit lower. Obese patients, they have a lot of pants. They have a lot of stuff. There's a lot of restricted motion of the diaphragm. If those patients you go all the way down, you're just going to see abdominal structures. So start a little bit higher on your obese patients. And this is a little bit of a way that you can critique your own images. Your parasternal long axis, really, you want to get down that like the longest, like the widest part of your LV. If you're starting to see these papillary muscles come into view, like often you see the papillary muscles just kind of come into view at the bottom, you know that you're what we call closing off your LV, and you may overestimate your LV ejection fraction, and you're not actually seeing the actual size of the LV. And then look at chamber sizes. I'm sorry, guys. This is in cardiology view, not in the. So everything that you know on the left is on the right. So the RV, aortic outflow tract, and the LA, you know, should be 1 to 1 to 1, right? The rule of thirds. So when you're doing your parasternal long axis, don't just look at your LV function. Please look at the chamber sizes as well. Clearly here you see that the RV is pretty big, right? On both images. But again, I would never call that the RV is big on just one image. Please do your parasternal short, do your apical 4. If the RV looks big on all of those images, then fine, you can go and report that your RV is big, right? Aortic root, I'm going to let Esteban talk about most of this. But again, clearly you can see that the aortic root is really, really big here. If you want, you can try to go up an interspace on the lungs, and you can catch a little bit more of the ascending aorta. This is one of my images. I was like, what the hell is this? Is my parasternal long axis. I don't know what I'm looking at. This is a 6-point-something centimeter TAA with a dissection and a pericardial effusion. He died an hour later. So ejection fraction pitfalls, EPSS. I hear about EPSS all the time. I don't know. I have my own feelings about it. And it's great in the emergency department because it's really quick. You take one view at it, you look at the mitral valve slapping the septum, and you're like, okay, I'm done. But know the pitfalls when you decide to use EPSS. You're using, the LV has 17 segments. You're using 2 segments of the heart to estimate the function of a 17-segment structure. That is most likely not the way to go. And so know the pitfalls, right? So any perturbance of the mitral valve, right? So aortic regurg, if you have rip-roaring aortic regurg, that mitral valve is not going to slap the septum no matter how good your LV function is. So you're going to say, oh, the EPSS is low, so the LV function must be low. You can't say that, right? If you have mitral stenosis or like in a patient with ischemic cardiomyopathy, there's a lot of tethering of that mitral valve. So the mitral valve is not moving as you would like it to. You can't use EPSS in those situations. If you have regional wall motion abnormality, so in the parasternal lung, you're seeing the enteroseptal wall and you're seeing the infralateral wall. If you have wall motion abnormalities there, someone had an infarct a long time ago and you have an infarcted in the infralateral wall and it's not moving very well, you can't use EPSS in these situations. But if you have a normal person and a normal heart and you're seeing obviously the septum is being slapped by the mitral valve, sure, you can use EPSS as a way for you to say that LV is probably normal. We talked about closing off the LV a little bit. And then lastly, visual estimation is probably the best way, one of the better ways to go. But the caveat is you better have done a bunch of echoes in order for you to say, oh, I can tell by just looking at this, the LV is normal. Okay. Effusions. So there's 2 types of effusions that you can see, pericardial effusion and pleural effusions. Sometimes you get confused. I'm like, I don't know what this is. It could be both. So you use the descending aorta here as a landmark to see whether this is a pericardial effusion or pleural effusion. Anterior to the descending aorta, probably a pericardial effusion. Posterior to the descending aorta, probably a pleural effusion. And if you see the pleural effusion on your echo, please do a long ultrasound to confirm that. Parasternal short axis, not much here. Get a great plaques view, you're going to get a great parasternal short axis view. Your parasternal long axis is here, short axis is there, just a 90-degree turn. So concentrate on getting that good parasternal long axis, keep that in your image, and rotate 90 degrees. D sign, ventricular interdependence. Oh my God, I hear about D sign all the time, right? Please make sure the D sign is real. If you rotate your probe just a little bit, we can simulate it today if you want. I can create a D sign on anyone that I see. So, but if you see the D sign, again, same thing as your plaques view, same thing as your apical 4 view, please make sure that this is real. I'm not going to go over this. Apical views. So you want your intraventricular septum to be in the middle of the screen. You want to try avoiding seeing the papillaries, although a lot of times it's hard to do. Your LV should be around 2/3 and your LA should be around 1/3 in a normal heart. So apical 4, all the time we see foreshortening all the time, right? But you want to get to that apex of the heart, and you want to, so the heart, when it sits in your body, the way that the heart actually moves is that the base of the heart rotates, kind of twists towards the apex. The apex is not what's moving. But when you foreshorten your image and you're actually getting one of the walls that are actually moving, you're going to all of a sudden see this. That's, you know that you're foreshortening if you're like that, right? You want your heart to look bullet, your LV to look bullet shaped, and if you're looking egg shaped, you know that you're foreshortening. For example, on the left, definitely a nice egg shaped looking heart, and that left atrium looks huge. It's not that the left atrium is huge, you're just foreshortened. The image on the right is more of a classic apical 4. The 4s are in here, so I'm just going to talk about this. We might be able to simulate it today. Your apical 3-chamber and your plaques view are on the same axis of. You're looking at the same exact walls. It's easier when we do it on the actual model, so I'll pass over this. So if you're having a tough time looking at your plaques view, if you are able to get an apical 3-chamber view, it's a second try at the same views. Subcostal views. Best place to look at the RA, RV free wall, very sensitive for pericardial effusions. Best place to look at the interatrial septum. So if you see a giant hole there, put a little color flow on it, see if there's any sort of jet going across the atrial septum. So sometimes these patients are so hyperinflated, you can actually do your long axis from the subxiphoid area. Subxi short, sometimes you really can't get it on your parasternal lung views. Parasternal views, try rotating over to the patient's heart, and you may be able to get that. Take the IVC view and just rotate the other way, and you may actually get a subxi short view.
Fan over.
Yeah, fan over. And this is basically what you're doing to try to get that subxi short. IVC, all of you know this. I'm going to skip over this, and I will skip over the optional.
Okay. We're going to talk about tamponade real quick before we get into the ultrasound. Is all the clinical signs that you see that you learned in medical school about Beck's triad, that's peri-arrest, peri-mortem. So ultrasound, we're trying to find the signs of tamponade before the patient gets critical so we can intervene appropriately. Sad. So sad. So sad. It's not moving.
Boo.
What do you mean? Up, down? Oh, wait, what?
The video.
All right, cool. All right, here we go. So physiologic point to understand is this idea of ventricular interdependence. You have the right side of the heart, left side of the heart competing for a confined pericardial space. In normal physiology, when you breathe in, you have an increased venous return into the right side of the heart that increases RV pressure, that pushes the RV into the LV, and it outcompetes the LV. What that means is that your cardiac output during inspiration is lower, while conversely, in expiration, because you have increased intrathoracic pressure, now the RV doesn't get that much filling from the venous side. That means the LV is able to fill more. It wins in terms of space, and thus the cardiac output is higher. So this is about a difference in BP of around 10 millimeters of mercury. So once you understand ventricular interdependence, tamponade, all it does is it exaggerates that ventricular interdependence, because now you have effusion surrounding the heart, and it's putting pressure on the chambers. And because the right side of the heart is a lower pressure system, it's going to be the first to lose out. So as the effusion pushes on the right side of the heart, pressure increases of the RV, and it's also getting venous return during inspiration. So now there is an exaggeration of the right side of the heart pushing into the LV. So you have an even greater difference between the BP during inspiration and expiration. That's what we know as pulsus paradoxus. Read about it. Takes a bit to understand. So big thing to understand about effusions, doesn't matter the size, it's the pressure of the effusion, right? Did the pericardium have time to stretch to accommodate that increasing pressure? Once they reach a threshold, you lose diastolic filling, you lose coronary perfusion, and then your patient goes into arrest. The big point to understand here is that a quickly accumulating effusion at 40 to 50 cc's, you already have physiology. While patients like lupus, malignancy, they can accumulate up to a liter of pericardial effusion before they actually display tamponade physiology. So it's about the pressure and the time that the pericardium has to stretch. All right, the 4 ultrasound findings. If anything from this lecture, these 2, okay? RV diastolic collapse, plethoric IVC. The other 2 are bonus points, RA systolic collapse and respiratory flow variation. This is like more nerdy ancillary finding. So RA systolic collapse, it is the first thing to happen. The RA is the lowest pressure system of all the chambers, so the effusion will impact it first. You're going to find it in your subxi and your apical 4, and all it is when the tricuspid is closed, when it's filling, the RA is going to be bowing into its chamber. And again, you'll see it on the subxi and the apical 4. And then this video. So right here, you see that free wall of the RA pushing in. And then same thing here. And then he'll switch over to the subxiphoid view. Here you can see it much more clearly. Cool. Awesome. Now, this is probably going to be your go-to. Good workout. RA diastolic collapse. Plaques view, parasternal long. It's the same M mode that you're doing to get your EPSS score. Press the M mode again. You'll get these waveforms. The dot of the red here, that's the mitral valve. Sick. Awesome. Amazing.
Yeah.
So
I like that one better.
Keep pulling up.
mitral valve, and this is the RV free wall. During diastole, it should be opening. It shouldn't be dipping in. So this is no bueno. Okay. If you see the RV free wall dipping in as diastole is occurring, this is RV diastolic collapse. It has a better specificity than your RA systolic collapse. Still not the best, but you're going to use it in conjunction with all the other 4 findings to really build the case of tamponade. And now the next one.
What access are you trying to get?
That is your parasternal long. So you're going to do parasternal long, do your MO through the anterior mitral leaflet. Exactly the same. It's the same. If you guys know how to do EPSS, EF, this is the exact same waveforms.
And we all love EPSS.
Yes.
We all love it. So
Right, James?
It's cool.
It's foolproof. Yeah. It's actually better than looking at the 17 seconds. All right. So see, open collapse. Cool. You guys get it?
Got it.
Got it. Good. Oh, this one doesn't load. And then this, if rarely, you'll see both RA systolic and RV diastolic collapse. Sad. So you see both of them happening. This is the trampoline sign. But if you don't see RA systolic and RV diastolic collapse, that has a 90% negative predictive value. All right, cool. Next one is IVC evaluation. We all know how to do this. Go to your subxi, twist it, look for the IVC. The important thing to remember is that if you're going to measure the diameter of the IVC, it's 2 centimeters from the junction of the RA and the IVC joining together. So what I like to do is take my measurement, put it at the junction, measure out 20 millimeters, and then measure the diameter. So if the diameter is greater than 2.1 centimeters and the collapsibility index is greater than 50%, sorry, less than 50% during inspiration, then it's concerned for plethoric IVC. And these machines have auto IVCs. And then we all have seen plethoric IVCs. This one works. Yeah. Cool. Just remember to measure out to the right spot. So the last one, which is more of an ancillary finding, is respiratory flow variation. So in like a true tamponade that is about to crash or getting close to crashing, you will have RA systolic collapse. You should see RV diastolic collapse. You'll see a plethoric IVC. Though you would not see this and not see the rest, right? This is at least very, very early, not yet tamponade. This may clue you in that something might occur if you don't see any of the other findings. So respiratory flow variation just goes back to that point of ventricular interdependence. Because tamponade has exaggerated that ventricular interdependence, the change in the E wave, the flow of blood into the left ventricle, is exaggerated because it's now less during inspiration. So the difference between the E wave of expiration and inspiration is greater. And what you do in terms of how to actually get this, you go to your apical 4, you put your pulse wave Doppler right above the mitral valve opening, and then press it again. You'll get this run through waveform of E waves, and you'll measure the shortest E wave to the tallest E wave. If that is greater than 25% difference, then you're concerned that there is flow variation because of an exaggeration from the effusion. There are all the other valves you can do this study on too, but the highest sensitivities and specificities have been seen in the mitral, so I would just suggest go for the mitral. So summary, clinical findings, not good. Patient's gonna die. Absence of RA systolic and RV diastolic collapse together, 90% negative predictive value. A normal IVC has also a high negative predictive value. Studies that I looked at didn't actually give me a number. They just said it's high. I was like, okay, cool. Flow variation is, again, an ancillary finding. And JFK was saying last time, you can 100% have, in very rare zebra cases, patients that are very fluid down. And so their IVC won't be plethoric, but they will still have tamponade physiology. So that's why we look at all
Such a rare exception, like definitely always go through the process of looking at it every time we think.
All right, cool.
All right, so this one's gonna be mostly on here. We're gonna be talking about aortic dissection and ultrasound, okay? So this one's mostly, you need to see the video, so we're just gonna do it all here. So picture this, you're on CCT, you know, tilt it over, there we go. CCT shift, room's a little busy, as it always is, all right? When you get a call on the red phone, all right, the EMS is telling you they're bringing in a 50-year-old female, essentially for shortness of breath and collapse. All right, that's all they really give you. The vitals are like generally normal, maybe a little tachycardic, but that's it. All right, patient eventually rolls in. You notice that EMS is bagging her. All right, so not great. They have a little bit of extra story. She was banging on the door of her sister saying she had chest pain, and then she collapsed. With EMS, they needed to bag her. They have no other information, essentially just hypertension. All right, so you don't really have a lot to go off of. You move her over to the bed, you do your ABCs. She's not breathing on her own, so you're assisting ventilation. She does have bilateral breath sounds. You're having a really hard time getting a good blood pressure. EMS reported like 120/80, not really believable here. All right, disability-wise, not really moving anything. And no signs of trauma. So not great. You start preparing for intubation. You start working on getting access. And you put an ultrasound probe on the patient just to kind of get a look. And this is what you see on the subxiphoid. So here you see a large pericardial effusion. You see some hyperechoic areas in there. And the aorta looks a little dilated to you.
Just like real sound.
Because in reality, you are freaking out at this point, all right? Your knees are weak. Your palms are sweaty, all right? Because you are concerned this patient may have an aortic dissection and a hemorrhagic pericardial effusion, okay? And so today our lecture is going to be on how ultrasound can help us diagnose this earlier. Now, the first question is why? Why do we need a diagnosis early? Well, mostly mortality risks. There's like a 27 to 40% chance of mortality by just having these aortic dissections. So terrible. It increases 1% for every hour that they don't get definitive treatment. All right, so we want to diagnose these early. How do we normally do this in the ED? So a good physical exam, we listen for signs of, or like regurg maybe, listen for murmurs. We do a pulse exam, we do a neuro exam. Maybe we toss in a chest x-ray in there looking for a mediastinal widening. But ultimately it's a CTA, all right, with the sensitivity like 99 to 100%. The issue is that sometimes it takes a long time to get these studies. Even in CCT, when you're really trying to get things moving, this can take some time to do. All right, so how can we diagnose this a little earlier? Now, I argue that ultrasound can kind of help us do this. All right, particularly it can help us diagnose early, even before we do a good physical exam, to be honest. All right, and definitely before an x-ray, definitely before a PTA. All right, so let's go over a case. This was a code heart that was called. I go and echo just because I'm interested. I'm looking for wall motion abnormalities, and I don't really see anything that has concerning for like a STEMI. But there was a little subtle abnormality. It's kind of hard to see in the back. But otherwise, for me, this was generally a normal echo, except for one thing. When I looked at the descending aorta on the peristaltic long axis view, and you zoom in on it, you actually see an intimal flap. So this patient ended up changing from a STEMI, where they're going to get aspirin, Plavix, heparin transfer, to now a patient with a descending aortic dissection. And you can see it a little bit better on the apical 3 chamber and here on the descending aorta. All right, and this absolutely changed management, and it wasn't particularly difficult to do. All right, I was doing my normal views when I picked up on this. All right, and I explored a little bit more on some kind of easier views that we can do, and this completely changed management for sure. All right, so first point, the views are easy to do. You can pick up on a lot of these on just the normal views that you're doing. All right, but there are also extra views that you can kind of add in to try to explore this a little further. We're going to go through these. The peristernal long axis view we already do, the apical 5 chamber. We're going to talk about introducing the suprasternal view, and then the subxiphoid view. We'll talk about extra things you can do there. So with the peristernal long axis, normally we're looking at the descending aorta, see if there's a dissection flap. We're using the rule of thirds, making sure that the RV is the same size roughly as the aorta, is the same size as the left atrium. And then we're taking a special look at the aortic valve. Sometimes you can throw color on there too, maybe see some regurg. All right, that's what we normally do. But what I want to recommend, and this one's hard to see, but try tilting the ultrasound probe a little bit further up, so you see a little bit more of the aorta than you normally do, because you really only see the aortic root on the peristernal long axis view. So if you rock the probe just a little bit higher, you can actually see a little bit more of the aorta there. And when you're up there, try fanning through. Unfortunately, these are really subtle findings, but if you fan through and you pick up a dissection that happens to be a little bit to the left or the right of where your initial cut was, you can pick up on a dissection early there. And same thing with the apical 4-chamber view. As you kind of rock or cut through, you actually see a dissection flap there. That is subtle, that you would not have picked up on your regular apical 5-chamber view. So again, the tip here is to rock and fan through the aorta to see if you can pick up on these subtle findings that you wouldn't have had you just done your normal view. Next one, the suprasternal. So the idea of this is that the aorta goes from the ascending arch descending right behind the suprasternal notch here. All right. So if you get the cardiac probe with the probe marker pointed up, if you rotate it to like 30 degrees clockwise and then try to point down, and you can ask the patient to lift up their chin, you actually should be able to see this. Sometimes you can see the ascending aorta, you can definitely see the aortic arch, and then usually you can see the descending aorta as well. This is stuff that you cannot see anywhere else on any other view except for CTA, but this you can do at bedside. All right, and sometimes you can even pick up subtle aortic dissections here in the arch going into the proximal descending aorta. And you can do the diagnosis earlier than anything else. All right, and then the subxiphoid view. So in the context of like chest pain, collapse with the pericardial effusion, that's pretty high risk for having a dissection. But extra things you can do when you're looking at the IVC, try fanning over and looking at the descending aorta just while you're there. It's very simple to do, and you can pick up a little subtle descending aortic dissection that way. So what's the evidence? Why should you do this? So earlier this year, there was a study. They used something called the SPEED protocol, where all patients suspected of having aortic dissection got a cardiac ultrasound and a AAA exam, essentially. And this is not like a full TTE. This is just kind of our point of care ultrasound. Out of around 1,300 patients, 44 patients ended up having aortic dissection. And there was 3 findings that increased their likelihood of having a dissection. And these 3 findings were a pericardial effusion, an intimal flap, of course, and then an aortic outflow tract diameter greater than 35 millimeters. Essentially, we're not going to measure this, but we're going to eyeball it and say that aorta looks huge compared to the RV or the LA. And they found a sensitivity of 93.2% with this and a specificity of 90.9%. So again, this isn't 100%. This is not kind of the end all be all. But if we want to compare this to what we are already doing, things like chest X-ray, this has a sensitivity of 64% and a specificity of 86%. You know, we have a better test that we can do even quicker. So why not just kind of incorporate this into our practice? So let's go back to the first case. All right, so we see this on the subxiphoid. We finally get a good blood pressure. He's hypotensive. She's tachycardic, like 140s. Let's say he's kind of circling the drain. And you only have one kind of etiology at this point. So you go and you do the pericardiocentesis. And you take out 10 cc's of bright red blood. Very terrifying. You don't take out any more than that. Blood pressure gets better, heart rate improves. This kind of confirms for you that this is a aortic dissection. This is a hemorrhagic pericardial effusion. You get your services on board, you work on transferring. Because the patient stabilizes, you get the CTA, ascending and descending dissection, just massive. And the reason I talk about this case in particular is because this is a real case that me and Natalia had. And we transferred this patient with no mental status still. And I was concerned that, we just kind of made this lady like no mental status, is going to go to a nursing facility even if she survives. But after a 3-month stay in the hospital, she was actually ANO times 3. She can move her right arm. She's plegic on her other extremities, but at least she's alive. All right, so this leads into the final point. Ultrasound is operator dependent, meaning that the difference between what I can do, what you can do is different. But that's also the exciting part, because this really means that with deliberate practice, with kind of incorporating the things that you're doing, you can actually be the person to diagnose dissection early, start treatment early, maybe even save a life. All right, so the take-home points. The views are easy to do. We can just add them to what we're already doing. Try rocking and fanning through the aorta while you're in these views, just to get a better look, just to see if you can pick up on these subtle findings. And it's operator dependent, meaning that you guys can do this. All right, and that's it.